Why I left standard cardiology and built Pulse Perfect. I want to tell you something that most doctors won't say out loud. The standard cardiovascular workup, the test your PCP orders, the test most cardiologists run, was designed to find disease that is already causing symptoms. It was not designed to prevent disease before it causes an event. That distinction sounds subtle. It is not. It is the difference between a cardiologist who fixes a heart after a heart attack and a cardiologist who prevents the heart attack from happening. I'm board certified cardiologist. I trained in an excellent program. I know what the guidelines say. And then I started seeing what precision tools could reveal. And I knew I had to build something different. I want to be clear about something before I explain why I built Pulse Perfect. Standard cardiology is excellent at what it was designed to do. Interventional cardiology saves life. Stenting, bypass surgery, device implantation for arrhythmias, and heart failure. Heart failure management has transformed outcomes. Atrial fibrillation treatment has never been better. The guidelines for secondary prevention, statins, blood pressure management, antiplatelet therapy after MI, are evidence-based, well-constructed, and when followed, they work. I'm not here to criticize the field. I trained in it. I respect it. What I'm saying is that there is a gap, a specific gap, between what standard preventive cardiology offers and what is actually possible with the tools available today. And most patients and most physicians do not know that gap exists. The gap is this. Standard preventive cardiology relies primarily on risk scoring, Framingham, pooled cohort equations, ACC-AHA risk calculators. These tools take your age, sex, blood pressure, cholesterol, smoking status, and diabetes status and produce a 10-year cardiovascular risk estimate. These are population level tools. They tell us average risk of people with your combination of risk factors. They do not tell us what is happening inside your coronary arteries right now. A 52-year-old man with a pooled cohort 10-year risk of 8% might have a completely clean coronary system, or he might have subclinical multivessel atherosclerosis with a calcium score of 158 and non-calcified plaque that would be missed entirely. The risk score doesn't differentiate, and without imaging, neither does the physician. The second part of the gap is the lipid panel. The standard lipid panel was developed in the 1970s based on the tools available at that time. We now know that LDL-C is a less accurate predictor of cardiovascular risk than ApoB. We know that LPA is an independent, genetically determined risk factor affecting 20% of population that is never on standard panel. We know that LDL particle number and pattern matter more than cholesterol content. And yet, most lipid panels ordered today are identical to the ones ordered in 1985. The third part of the gap is fitness. VO2 max is the most powerful predictor of cardiovascular survival in the literature. It is not a standard clinical assessment. Almost no cardiologists test it routinely. When I saw these three gaps simultaneously, imaging, lipid assessment, fitness, and saw the tools that could close them, I knew what I needed to build. Let me tell you about 4 patients, all anonymized, all real. The first was a 52-year-old marathon runner. His standard labs looked borderline, acceptable. His doctors had labeled him borderline and credited his running. He had no symptoms. His calcium score was 158. His non-calcified plaque on coronary CTA was actively modifiable. His ApoB was 102, significantly elevated despite a standard LDL of 118. He had subclinical multivessel disease. His prior physician had no idea. The second was a 48-year-old pharmacist. Coronary calcium score of 0. Normal stress test, normal echo, all reassuring. Coronary CTA revealed 70% proximal LAD stenosis from 100% non-calcified plaque. FFRCT confirmed hemodynamic significance. He needed stenting. He was 4 months from a major heart attack. The third was a 56-year-old woman. She had seen a cardiologist, normal echo, told to return as needed. Her LPA was 88.3. Her LPIR score was 76. Her VO2 max was in the bottom quartile. Her fit age was nearly 4 years older than her chronological age. She had early LAD plaque, atherosclerotic cardiovascular disease confirmed, despite a calcium score of 0. None of this had been found. The fourth was a 55-year-old man with hypertension, diabetes, and hyperlipidemia. He had been cleared by a cardiologist, normal stress test, normal echo, normal cardiac monitor, twice. Coronary CTA, multivessel coronary artery disease, calcium score of 162. Mid-RCA stenosis at 50 to 60%. FFRCT told us it was not yet flow limiting. So we treated aggressively with medications rather than stenting. But this man needed intensive secondary prevention, and he had been told twice he was fine. 4 patients, 4 near misses, all with normal standard workup, all with significant actionable cardiovascular disease. These patients did not fall through the cracks of a broken system. They fell through the gaps of a system that was doing exactly what it was designed to do. And those gaps are real. The tools I use at Pulse Perfect are not experimental. They're validated, guideline supported, and used in the world's leading academic cardiovascular centers. What is unusual is making them systematically available to patients who need them, not just in trial settings. Coronary CTA with AI plaque analysis tells us exactly what type of plaque is in each coronary vessel, in what volume, and at what stage. Heart flow FFRCT, computational fluid dynamics from CT imaging, non-invasive physiological assessment that guides intervention decisions without catheterization. NMR or cardio IQ lipid profile with ApoB and LPA, LDL particle number, particle size, LPIR insulin resistance index, the complete lipid picture. VO2 max with ventilatory threshold analysis, the gold standard of fitness assessment. Zone 2 and Zone 3 prescriptions individualized to each patient. DEXA body composition, not BMI. Visceral fat volume, lean mass, RSMI, android to gynoid ratio. True age epigenetic testing, omni-C age, organ system ages, pace of aging, fit age. Biological age is not the same as chronological age, and the gap between them is actionable. Each of these tools close one of the gaps I described. Together, they give a picture of cardiovascular health that is simply not available from a standard workup. The tagline of Pulse Perfect is 3 words: screen, optimize, excel. They're not marketing words, they are a clinical philosophy. Screen means finding the full picture, not just the obvious findings, not just the symptomatic findings, the subclinical disease, the genetic risk factors, the fitness deficits, the metabolic drivers, the biological aging patterns, all of it before it becomes a problem. Optimize means treating precisely, not just initiating a statin and telling someone to exercise more. ApoB below 60, VO2 max improvements as a clinical endpoint, insulin resistance addressed at its root, blood pressure optimized, GLP-1 agonist when the SELECT trials tells us they should be used, CGM guided glucose management for pre-diabetes reversal. Excel means the goal is not to avoid a heart attack. The goal is to live fully, to be physiologically 10 years younger than your chronological age, to have the fitness of someone a decade, year junior, to have the metabolic profile that keeps your arteries clean for the next 40 years. Every patient at Pulse Perfect is treated as someone who deserves to know their full picture and who deserves a plan precise enough to act on it. Every patient at Pulse Perfect receives a Pulse Perfect 360 blueprint. This is a 35 to 40 page personalized document, not a patient summary, not a visit note, a precision longevity plan. It integrates every data from the evaluation: coronary plaque burden, advanced lipid results, VO2 max and training zones, body composition findings, epigenetic data into a single narrative with clinical interpretation. And then it translates that data into action. Specific 90-day targets, a phased action plan across 3 months, a personalized zone training prescription with exact heart rate targets, a nutritional framework tailored to the patient's biology and cultural background, a supplement protocol with dosing rationale, and daily morning and evening routine recommendations. Complex medical data is only valuable if a patient can act on it. The blueprint closes that gap between diagnosis and behavior change. It is the deliverable I wish every cardiologist gave to every patient. I built Pulse Perfect because I believe patients deserve more than a risk score and a statin prescription. If you have ever felt like your cardiac workup was incomplete, if you have ever passed a stress test and still wondered, if you want to know your full picture, that is exactly what we do. Pulse Perfect is in Piscataway, New Jersey. If this video resonated with you, please share it